Thanks for tuning into the NorthLakes podcast. I'm Jeremy Oswald, your host for today. Today we talk to Dr. Dodson Thompson about colon cancer screening. We find out what's in his car and learn a little bit more about NorthLakes Farm to Patient program.
My name is D. Thompson. I'm an osteopathic physician here at NorthLakes Clinic in Minong. I will have been here 15 years on October 1st, which seems like a long time. It's actually the longest I've ever been in one place in my entire life, except the town where I grew up. So that's a big deal for me. It's been a great 15 years. I love Minong. I love the Hayward area. I've developed what I think are really good relationships with my patients, and some of them feel like family, and that's really important. It can also be very hard as well when you lose them, but yeah.
I'm sure you've gotten to the point where you're seeing kids of kids, or maybe not that, but are like you've seen probably multiple generations?
Pretty close. I now I'm to the point where I see early in my career here, I delivered quite a few babies, and I have teenagers myself. So my daughter, who's a freshman in high school, actually has a couple friends who I delivered. So it's not very weird for me, but I mean, the kid, they don't really remember me, but it's a little strange for my daughter. She's like, I can't believe you delivered her. But that's what happens.
Oh,
so it's interesting.
And have you when I drove into town here, I remember hearing from the history of NorthLakes that we used to be in the laundromat that was around down the street. Were you here that?
No, we were always in this building. Now the building was a lot smaller when I first came here, but I was always in this building.
So I've been lying to people.
Well, it was, but I don't know what year they switched from the laundromat to this building.
Okay, so there was at one time. Okay, so
that's true.
I'm not lying.
No, you're not lying. It's just that predates me a little bit.
Got it. So I wanted to talk to you about, and tell me if I'm saying this right. It's colon cancer, colorectal cancer screening. Am I saying that right, or how is it referred to?
I usually refer to it as colon cancer or colon cancer screening, though the specialists will differentiate in the colon and then the rectum, because you can have different types of cancer in those regions. We screen for it the same way. There's no difference in how we screen for that, but so I generally use just a bucket term as colon cancer.
Great. And what is it?
It simply is it's adenocarcinoma of the colon, which, like any cancer, are fast-growing, undifferentiated cells, which if we let them grow and spread, much like any cancer, they simply crowd out the normal cells and take over the function of those normal cells, and then therefore your body can't function that way.
Because those cells have taken over that area, and they're doing that their job of their job.
Yeah, they're using all the nutrients and in some cases putting out causing other things to happen in your body, such as blood clots and things like that just aren't amenable to healthy living, so to speak.
And are there symptoms?
The number one symptom we look for is obviously someone who has blood in the stool. That doesn't mean blood in the stool itself doesn't always mean you have colon cancer, but certainly it's concerning, or what we call dark or tarry looking stools. And there's other reasons to have blood in the stool. You can have a situation called diverticulitis, which is an inflammation in the colon which can bleed. You can have hemorrhoids, which can cause bleeding. But blood in the stool is one of those terms where when we hear that, we as physicians, we perk up a little bit, like, we need to look a little deeper, so to speak. Abdominal pain can be a symptom when the cancer progresses along. You can also have bowel obstructions where all of a sudden you can't pass stool anymore, which would obviously lead to abdominal pain. Colon cancer was usually, we screen for colon cancer with a colonoscopy. Now, there are other screening tests we do that are less invasive, where you can take a stool sample and test for fecal blood. There's a new test called Cologuard that's been it's been approved for 3 to 4 years now, where they look for some other markers produced by precancerous polyps. But the gold standard for screening for colon cancer is still a colonoscopy, and that simply is a experienced general surgeon or gastrointestinal specialist inserting a camera into the rectum and going all the way through the large colon, looking at the large colon or the large bowel, finding any polyps which can be precancerous in nature and lead to colon cancer, and removing those. And that really still is the gold standard and what I recommend to most people. We used to recommend that we start colon cancer screening at 50, but within the last 18 months, that recommendation has moved down 5 years, has been decreased by 5 years. So now we're recommending anybody over 45 can qualify for colon cancer screening. The reason for that is we've just started finding more colon cancers in people younger than 50.
And when you say qualify, I think that means that insurance will pay for it?
Yes.
Generally?
So I think the first physician society that came out and recommended that we move the guideline from 50 to 40 was the American College of Surgeons. And then the American Cancer Society got on board. And once you have a large physician group like that, or a large society like that, say we need to move those guidelines, then generally insurance is gonna say, yeah, we need to do that.
Got it. And so why is it important to detect this? I mean, I'm kind of giving you a softball here. I think it's a deadly disease.
It is. And I don't know the number off the top of my head as far as colon cancer and how many deaths that causes in the United States yearly and how it ranks to other cancers. But I'm pretty sure it's in the top 3.
I think it is number 3. I did a little research, but I could be. It's in the top 5.
Yeah, certainly. The really interesting thing about colon cancer, and I'll back up and talk about screening, because everybody wants to talk about screening and how we go get a screening test and that means we don't have the disease. Well, that's not always the case. There are some screening tests we do that may not be as accurate as we would like them to be. Mammograms are one of those. There can be a high number of false positives with mammograms. So where something looks abnormal on a mammogram and then you do further testing, such as a biopsy, and find out that it's not anything serious. Colon cancer screening is, when I say it's a gold standard, is a colonoscopy as the gold standard. They're very accurate and very, very sensitive to finding colon cancers and preventing colon cancers. It's what I tell my patients is colon cancer screening works. If you get a colonoscopy at the age of 50, which again I still kind of fall back to the old guideline, and you have a normal colonoscopy, you don't need another one for 10 years. Simply because those polyps, if you had any polyps, they're so slow growing that they've looked at the pathology of the disease, the epidemiology of the disease, and it takes that long for that polyp to develop into something serious. And so you can feel very comfortable that at the age of 50, if you had a normal colon cancer screening, a colonoscopy, then you don't have to worry about colon cancer. for at least, most guidelines say 10 years. If you do some of the other screenings, such as the Cologuard, those are good for 3 years. So I really like the Cologuard screening because it's sensitive.
And what is that? So how do you do that? How would somebody do that screening?
I put an order in the computer. The company is out of Madison, Wisconsin. It's called Exact Sciences. They send you the test kit. You send them a stool sample. They send me the results, and I pass them on to the patient. And they're looking for markers, specific markers from types of polyps that can indicate you've got precancerous polyps. So if those markers, those genetic markers are in the stool sample, then they're going to recommend a colonoscopy. If they're not, then you're good for 3 years and you repeat the Cologuard. I'm becoming more comfortable with the test, especially in low-risk individuals. I do not think in individuals that have a family history of colon cancer that test is applicable. I would still feel more comfortable that they get a colonoscopy.
And I'm guessing with some of those other symptoms as well.
Yes, yeah. Obviously, if somebody has symptoms, they're not getting a Cologuard. They're going to get a colonoscopy.
And that's so when you say gold standard, that doesn't happen a lot. So and that's kind of the key to this is that it's a deadly disease. But boy, if you can detect it, well, how is that helpful? Like what does that mean? Like you detect it early, how does it what happens next?
Well, the colon is an interesting organ in itself because we eat things that probably aren't the best for us. The colon that's where all your most of your nutrients are absorbed from your food, and where the body gets rid of all the waste. So it's a interesting organ that runs through your body and helps the body to get rid of the waste while maintaining this. It's dirty on the inside and clean on the outside. So and what I'm trying to say is it takes a long time for a colon polyp to develop into colon cancer. Most times, if you have a colon cancer that's detected early, it's relatively small, or it's in a small area of the colon. Surgeons can go in, they can take out that section of the colon that has the cancer in it, especially if it has not spread to any lymph nodes or anything else, hook the colon back together, and you never have any other issues. Now, depending on how much colon you have to have taken out, it can cause some digestive issues. But if you can take out a short segment of the colon, then your cancer is gone. It's surgically removed, and because the colon is very good at, I guess the word I want to use is isolating itself as being its own environment, and those polyps that lead to cancer again are very slow growing. So if you can get that cancer early, you don't need any of the chemo or the radiation or anything else. You do a bowel resection and off you go.
And I'm of the age that I guess it's been a year or so.
Yeah.
I had a colonoscopy, and I think I remember them saying that if they saw a polyp, they might try to take it out right then during the colonoscopy.
Oh, yeah, they usually do. They take a biopsy. Different polyps can have different degrees of cancer-causing potential. So if they see a polyp, they're going to take it out, and they're also going to base your return colonoscopy on how many polyps you had or you have. I don't know those exact numbers, but at a certain number of polyps, then you become a little bit higher risk. So instead of having a colonoscopy 10 years, they're going to do it at 7 years or 5 years or even 3 years.
Got it. And so there's a lot of people that don't do this. Or I don't know, I shouldn't say a lot, but do you know what's the why people don't do any kind of screening, be it the Cologuard or a colonoscopy or?
I'll be honest. Most people I can convince to do at least some sort of screening.
You're very.
I
I'll
think,
do anything you tell me.
I think I can convince most people to do at least some sort of screening, even if they don't want to do the colonoscopy. But even today, I had a patient who has a family history of colon cancer. She had her first colonoscopy at 45 because of her family history, and absolutely refuses to do another colonoscopy, not because of the procedure itself, but because of the preparation for the procedure, which, speaking from personal experience, having had a colonoscopy a couple years ago, the bowel prep of the process of cleaning out the bowel with the purgatives, the Miralax, and can be somewhat traumatic.
It takes a couple days.
It does. And if you ask me, the primary reason why people don't want to go through the process again, if they've had it, that's it. And I really think that's where if they had a normal colonoscopy the first time and they don't have a family history and they're low risk, they can probably be just fine with having a Cologuard as long as it's normal for the future screening test. And I think that's really where the Cologuard is beneficial and is going to find its place in the market. I don't think colonoscopies will ever go away. There's no, in my opinion, there's no alternative to having a well-trained, experienced physician doing the colonoscopies, looking at the colon, and seeing whether there's any polyps or concerning areas. But if you have a normal colonoscopy, I don't think there's any reason to say that for the future screening test that Cologuard can be your next best option.
And you can do those right at home. You don't have to come
in the office. All we have to do is order it. It's very slick, so to speak. I'm sure everybody has seen the commercials with I think they were in the Super Bowl this year with the poop emoji running around, and you put it in the box and send it off to Exact Sciences, and that's it. It's become a useful tool in the arsenal for screening for colon cancer.
And we don't need to get into this one patient story, but did you say okay, then here's another option for you, and are they going to go for it? Or
I did. I put in an order for the Cologuard today, and I'm not getting any payment from Exact Sciences. Exact Sciences, trust me. It's just it's a good test in certain segments of the population, and I use it.
And I've heard, I did a little bit of prep for this. We're trying to part of the reason I wanted to interview is that we're trying to do a little kind of a campaign to try to increase screening. So I have done a little bit of reading, and the reasons I've heard of people not doing it, one of them was that, if I'm going to get it, I'm just going to get it. So I don't know. Here I'm going to give you have the microphone. I don't need to give it to you. But what would you say to someone that has that attitude or thought?
I would argue that with colon cancer, with the screening that is available and the time period between the screening, that and the sensitivity of the screening, the accuracy of the screening, that there's really not a good reason that I can see to not have the screening. I don't think anybody out there that has had a family member go through chemotherapy or radiation for any type of cancer would ever say, if I have it, I have it. You only have to, and I do this for a living, so I have patients who go through this. But when you have a family member who does the same thing, who experiences the same thing, you never want to hear somebody say, "Well, if I have it, I have it." It's much more nuanced than that. And that's what I tell people. You don't, if you can take a colonoscopy takes some time. It's not the easiest. And the colonoscopy itself is easy because you don't remember it, but the prep and thinking about it are not easy. But if you can do that and then not have to do it again for 10 years and rest easy that you don't have colon cancer, that's what I tell my patients. There's no reason not to do it.
And you're right. I guess I'm with you, and I don't think a scare tactic is the best way. I don't want to be like, you should go because this has happened, but it's not, as I think, as you were saying, as simple as that. It's not like black and white. When you say you get it, it's like it's an ongoing awful disease that I'm guessing. I haven't been close to it, but I know you have.
Yeah, and it's something that you think about it every day, and you wait for the other foot to drop, and I tell my patients it's not something you want to have to deal with on a daily basis.
And so with the screening, are there any others? There's the colonoscopy, the color guard. Is there any other ones that you know?
Yeah, there's one other. We call it the IFOB, and it's a fecal occult blood test, and literally you do a stool sample, and it tests for the presence of blood in the stool, which can be a marker for an incipient cancer in itself, or a hidden cancer in itself, or a large polyp, which could lead to cancer. You have to do those every year. I've almost gotten out of the habit of even offering IFOBs because the Cologuard test, in my opinion, is a more accurate test, and you can spread out the interval from 1 year to 3 years.
Other physicians may have
that's mine, but but other physicians may use the IFOB much more than I do. I don't anymore because I think there's better options. But 5 years ago, for somebody who didn't want a colonoscopy, the IFOB was the go-to test. Yeah.
So I did send you these questions ahead of time, and it's funny, like I'm almost like squeamish reading this one, and it's funny, like I'm sure once I we've all been to the doctor, and it's funny, you get in the room with someone such as yourself, and some of the kind of social norms, as they should, kind of fall away. And so I'm going to just read what I went. My question is, this is about butts and poop, taboo topics. Does that make it hard to talk about?
Maybe when I first started as a medical student, it was harder to talk about. Not anymore. I talk with so many taboo subjects with my patients that talking about butts and poop is probably not that big a deal.
Not for you, but I'm just wondering.
For the patient.
Yeah, well, that's what I mean. Like, even like I am not a medical. Yeah. I do this for a living.
Yeah.
Talking to a microphone. But like maybe sitting around the table at home, when you're talking, like maybe it is a little taboo, to like come up with these. It's not something you usually talk about.
Yeah, it's not something you usually talk about, but I will tell you that I think in most cases patients don't have a problem talking about it. Like, especially if they're having an issue, like I'm having bleeding, they're going to tell you about it because most patients have been educated so much that bleeding is a bad thing that they want to come tell you about it. So. I don't find a lot of.
I'm not phrasing my question very well, I guess. I mean, I know it's not like, and even me talking to you, a physician, but I guess like if a family's, hey dad, hey mom, are you going to go get go get a screening? Like, and like, I don't know. Why are we talking about this? I don't even want to. Maybe I should talk to a behavioral health person about that.
I don't. Yeah, I don't really know. I don't know the answer to that. Sorry, Jeremy.
No, sometimes my questions are good and sometimes they're bad. So you did mention about once it's detected, how it's treated, It sounds like it is that's a pretty invasive move to remove part of the colon. Is that the option? Is that is how it's treated?
Well, it also depends on how large the cancer is and whether it's spread or not. So depending, if you have a cancer in your colon large enough to block the colon, obviously it needs to be taken out so you can have a normal digestive system. If it's spread to lymph nodes, then you start to get into the chemotherapy options and the radiation options. Sometimes the tumors are large enough where you have to get radiation to the site first before you can even before it's small enough where you can take it out. So there's a lot of different options, and going back to my medical school days, when I did a surgery rotation, I actually worked with a colorectal surgeon, and we did a couple bowel resections, which I assisted on. Which, when I tell people about doing a surgery rotation, it was the most fascinating thing I did. That you actually had this disease part of the body where the surgeon went in and cut it out and then hooked the other two parts together and off you went. And not off you went. It's not quite that easy, but that's the whole idea. So a really fascinating process. I don't know the numbers on this. I would think in today's world, with as much screening as we do and as much as screening is pushed, that we deal with much more earlier stage colon cancers than we do later stage colon cancers. So those surgeries where you take out a small portion of the bowel may be more common than the going to the radiation and the chemotherapy, which is obviously preferable anyway. It's obviously preferable to do the screening and get it before it happens. But yeah, unfortunately, cancer treatment today is much like it was 30, 40, 50 years ago. It's still the chemotherapy and the radiation. Once you're talking about cancer that's spread, there are other treatments out there, immunotherapies and other things. But yeah, once you get beyond the localized cancers, which would be confined to the colon, that can be surgically handled, then it becomes a much bigger issue, unfortunately.
I was surprised after my colonoscopy that I got a series of photos, and I could not believe how clear the photos were. And has that image always been so clear, or has that changed over the last
as long
since
as
you started? Or?
No, as long as I've been doing it, the image has always been clear. Yeah. And I used to get, when I was in residency, I would get photos of the colonoscopy from the surgeon, for my patients, and great, thanks for the photos, but I just really want to know what the surgeon said. Like, there's 3 polyps, there's no polyps, and I think most of my colleagues are still the same way. Like, great photos, just tell me what you found and where we need to go from there.
Maybe that's the photographer coming out in me. Maybe I may cut that right out there. Anything else?
Well, I did want to mention, and you and I talked about this before we started recording. We talked a little bit about the recommendation has gone from 50 back to 45 for getting colon cancer screening, and we've done that because we've seen more colon cancers in younger people. The experts aren't really sure why that is. I think a lot of experts think it's due to our diet, which is heavy in processed foods. And as we were talking earlier, there was a great article in Science magazine about 3 years ago talking about what we call the gut biome, because there's millions of bacteria in our colon, and most of those bacteria are good. And they're good because they help us break down all the sugars and the starches and the proteins, so they can be broken down into their base parts and used by our bodies. Feeding those those bacteria, heavily processed foods over a long period of time is probably, and I'm not even going to say probably, is not very good for our digestive system. Science Magazine had a great article where they went and looked for the perfect gut biome. Where are we going to find the people on this earth with the most perfect gut biome for digesting food and the healthiest gut? And they ended up going to probably the South Central Africa, where hunter-gatherers still live in the jungle, and they looked at what they eat, and during the wet season, when the animals move in, during the rainy season they eat more meat, not a lot, but some more. Well, during the dry season, when there's no animals around, all they eat is plants, and they eat a lot of roughage, a lot of stuff that our body doesn't do a very good job of digesting. And so what they found was this one group of people that they followed around, and I'm sorry I can't remember which country it was in, but they would have 5 to 6 bowel movements a day, which was completely normal because they're eating a lot of undigestible material. What they also found that they were eating is they ate a lot of honey, wild honey, and they ate a lot of the wild honeycomb. Like they would collect it and they would just eat the comb because they needed that energy during the dry season. And they had a great picture of this guy eating a honeycomb, and it showed his hand, and his hand was almost the amount of dirt underneath his fingernails on his hand was a little alarming. And then I had to step back and think, so what's really causing their gut biome to be good? Is it good because of what they're eating, or is it good because they're introducing all the other bacteria into the gut because they don't wash their hands, and their gut has learned how to create that perfect balance? I think it's an interesting question. When we look at our immune systems, there's been research, many years of research to show that a cleaner environment where you have less access to or less exposure to bacteria can create more autoimmune diseases and a less robust immune system. It's been shown that people that grow up on farms around farm animals have less autoimmune diseases, less asthma, less allergic reactions. It's actually healthier to have a pet in your house than not, as far as your immune system is concerned, to get your body exposed to some of those bad bacteria is actually good in a way.
I just get excited that you're excited about this.
Oh,
I just think that how neat that there's this physician in Minong that is like reading Science Magazine and like interested and still excited about it.
Yeah, I think it's fascinating. It's obviously we do a poor job on our diet in the United States, in the entire first world. We have created these large food deserts where people have access to large amounts of cheap food that is bad for them. And it's created and I digress a little bit, go off on a tangent, but it's created a society of people who are overweight, and then that leads on to problems that I deal with every day, which are diabetes and heart disease. Heart disease is obviously the number one killer in the United States, and our life expectancy for males in the United States has actually gone down because of heart disease. And it fascinates me a little bit that we don't allow cigarette companies and bourbon, alcohol companies to advertise on TV. Yet we let Burger King and McDonald's and Taco Bell do it. And I can tell you, I see a lot more people with diabetes due to their weight than I do people with alcoholic cirrhosis or lung cancer. So where do you draw the line between? How do you regulate that? Probably impossible, but it's a concern. The question is, though, is if everybody walked around eating honeycombs with dirty hands and had pets in their house, would we reduce our colon cancer rate? Well, that's the 100-year question, right? We'd have to. That'd be past my lifetime. So I don't know that. But those are questions that ruminate in the mind sometimes.
And I was going to say I didn't want you to name names, but you already did. But give us some examples. What do you mean by processed food?
Cheetos.
Okay.
I'll name some of my favorite processed foods. Cheetos is a processed food. Anything that can sit on the shelf that doesn't need to be refrigerated and doesn't go bad is considered a processed food. So, your processed foods are your frozen pizzas, your frozen dinners, and frozen vegetables aren't processed, but obviously the frozen lasagnas, and they have a large amount of salt, sugar, preservatives. Are they safe? Maybe not. I mean, looking at the fact that we're having more colon cancers, 60 years after these processed foods became a part of our lives, maybe they're not. I'm old enough to know that my grandparents grew up in the Depression. There were no processed foods, none. So now they had other issues, but processed foods wasn't one of them. And you have to delve deeper a little bit too. So if you go to a country where they don't eat a lot of processed foods, you can't just say, well, they don't eat processed foods because they don't have colon cancer, and therefore they don't have any colon cancer. Well, that may not be true. In some of these poor countries, we don't really know if they have any colon cancer because they're not doing the screening for it. So you have to be careful making those relationships, but those relations between those two things.
But this is it's one of the things that you stew about at night, or you're interested in. You're see, is there a correlation? I mean, just like I said, I think it's neat. You're just asking these questions, I'm thinking about it.
Well, that's what I personally think is interesting about what I do, is I get to think about those issues sometimes. All of a sudden, they're recommending now that you're 45 and you go get colon cancer screening because we're seeing more colon cancer. Well, why is that? What are we doing wrong? And I may be totally off base. It may have nothing to do with Hamburger Helper and frozen pizzas, but it's certainly something to think about.
And there's a farm to patient program here, isn't there?
There is.
I know what it is. Do you want to tell us what it is and how you use it, or do you use it? Share it with your patients? Yeah,
I think we have 18 patients here in Minong that are using the farm to patient program. Do you know where they get that? Is it?
I know where they do in Ashland. So I'm Ashland bias.
Yeah, here I think they get it from a farm in Stone Lake. So I don't think it's every week. Is it every 2 weeks?
I think it's every week, and I don't know. Let's say every week or two.
Yeah, every week or two. Patients sign up. They get a bag of fresh vegetables, from a local farm. I think last week there were some onions, there was some squash, some Swiss chard. Being a gardener myself, I like to look in the bag. And,
it is, right?
Yeah, see what somebody else is growing, and I'm missing here.
You go to the farmer's market just like me. I'm not buying, I'm just looking.
Yeah, I'm looking. I'm seeing what you got that I don't have.
Right.
And there's also recipes in there in the bag, basically trying to encourage people to eat a little bit differently.
And it is something that you can prescribe, right? I mean, I think the idea is that
it is a prescription that I have to prescribe it.
How does that work?
I simply put in an order for farm to patient in their chart.
And how do you choose? Is there a way you go about this person would benefit from this?
Actually, it's our patient
community health worker?
Yeah, our community health worker who recognizes or says this person is interested and they may benefit. We tried to do it with the physicians earlier, but it was just one more thing that we didn't think about very often.
It's nice to have that liaison that's kind of helping with that.
Yeah, and they're interacting with the patients on a different level, and certainly if the patient shows interest and they think they may benefit, then they're getting. And right now, all of ours are when it first started, you'd have 4 or 5 of the bags left over. People wouldn't pick them up. I haven't seen any bags left over this summer. So I think people are using it.
And you're looking because you're like, hey, what do you got?
Well, I am looking because again, you know, your carrots are. How come your carrots are way bigger than my carrots? But anyway,
they're professionals. What do you put in your garden? What do you like growing?
I'm a tomato guy.
Yeah.
Yeah.
They ripe yet?
They're getting there.
Okay, and I will say we are recording this the last day of August.
Yeah,
so.
Yeah, they're getting there. I'm a tomato guy. I haven't bought a potato in the grocery store in 8 or 10 years. That may not be the case this year. For some reason, potatoes look a little anemic. I grow my own garlic. I grow my own onions. Got a lot of Swiss chard, spinach, Brussels sprouts. I test collard greens for a seed company out of Iowa. So I have several different varieties of collard greens in my garden this year. And you'll just have to ask me. You'll have to ask me about collard greens later. I could talk for hours. But
that'll be our part 2.
Yeah. I kept my chickens away from my collard greens this year. So I hopefully will have a very good crop.
Excellent. And since we're kind of just talking here, I know you got I got another 10 minutes or so.
Like 2, 3.
2? Okay.
Yeah.
I got my last question for you then. What's in your car right now?
What's in my car right now? My workout bag is in my car. I have my bathing suit and my towel hanging off the back of the tailgate drying because I went swimming today. I have a invention in the back of my truck that I'm working on, and hopefully I'm going to put it on Shopify once my son and I redesign a little bit more. But that's all I'm going there because it's not patented yet. I have a bunch of crystals and rocks from my daughter, who will be a freshman in high school. She buys them because they help with anxiety. So they work together. And I think that's about all of the interesting things I have in my car right now.
That's a mouthful. Excellent. Dr. D, it's really nice to see you. I really appreciate you doing this. And it's a thrill to be down here in Minong. Thank you so much for the time.
Thank you very much, Jeremy. I appreciate it. Enjoyed it. Thanks.
Okay. Have a good day.
Yeah.
Dr. Dodson Thompson is a family physician at NorthLakes Community Clinic Minong. You can learn more about him by visiting our website, nlccwi.org. NorthLakes Community Clinic is a community health center with locations throughout the top third of Wisconsin. We see all people regardless of their ability to pay. I'm Jeremy Oswald, today's host of the NorthLakes podcast, and hope that you share this podcast and write a review. Please talk to your healthcare provider about getting screened for colon cancer, especially if you are over 45 and have never gotten screened. Thanks for listening to the NorthLakes podcast.